Yes, welcome to the channel. Today we have two topics that we are going to work on. We are going to finish paraphilic and sleep-wake disorders, and then we will do paraphilic and paraphilia disorders. Paraphilia disorders. Yes, and then we're gonna do sleep-wake disorders. It was a nice day yesterday. We saw issues that occur and go on with several issues when it comes to paraphilia and paraphilic disorders. A recap of what we did last time, and at least make us be at par on what we discussed. Mm, we discussed several things that most of them were legal issues, and others were non-consensual and consensual issues. Now, you see, mm, we have to go through at least a recap. We do at least what we learned last time, so that everyone can know where we are. Yes, where we are now. Okay. I'm still setting up things so that we can be okay. Still setting up things so that we can be okay. 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 Let's come. Hi, I'm back right now. Now, today we are finishing the recap of yesterday. Yesterday we did paraphilia disorders. Paraphilia disorders, we discussed about Paraphilia, which is defined as persistent sexual interest other than sexual interest in genital stimulation or preparatory folding with physical nature consenting human partners. Now, there are several things we discussed yesterday. Just a recap before we go to the topic of the day. The issues that we discussed yesterday, mm, there are several issues that we discussed, like exhibitionism, discussed about exhibitionism, voyeurism, exhibitionism, urge to expose other genitals to unsuspecting strangers, urge to expose uh, unsuspecting genitals to unsuspecting strangers. That's what we discussed yesterday. Voyeurism. Voyeurism, watching others undress or engage in sexual activities without consent. It's dropping on people without consent as they do their thing. That one is not okay. We talked about it, voyeurism. And then we have fraud, fraud, voyeurism. Voyeurism, touching or rubbing against non-consensual partners. We discussed about it. Sexual masonism, we talked about it, it's brutal. Masonism being sexually aroused by being humiliated, beaten, or made to suffer. We talked about it. Sexual sadism. Sexual sadism derived pressure from inflicting pain to inflicting pain or humiliation. This is sadism. Then pedophilia, we talked about children under 13 years. You remember we talked about children under 13 years. And then fetishism, sexual fixation on unliving object or specified body parts. And then we have transversing, sexual arousal from cross-dressing, transverse dressing. Physiophilia, sexual arousal from oxygen deprivation. That one is just a recap from what we talked about last time. Yes, we talked about the difference between this sexual and paraphilia and paraphilic disorders. Paraphilia and paraphilic disorder. You see, there is a difference. So, what is paraphilic disorder? What is paraphilic? There is paraphilia and there is paraphilic disorder. So, paraphilic disorder is a mental health condition. It refers to intense and persistent paraphilic interest that can cause distress, impairment, or involve harm to others. No, this is the difference between them. It it ref- that cause distress, impairment, or involve harm to others. You see, that's the difference. Uh-huh. Yeah, there is a big difference between paraphilia and paraphilic disorder, and that's what we are defining before we go to the topic of the day. You see, paraphilia paraphilia is not like paraphilic disorder. In this way, paraphilic refers to intense and persistent paraphilic interest that cause distress, impairment, or harm to others. You see, and paraphilic disorder is diagnosed when there is impairment or distress, or there is causing harm to others. And then we have uh, types of paraphilic disorders like exhibitionist, voyeuristic disorder, fruitoristic disorder, sexual masonism, sexual sadism, pedophilia in children, fetishism disorder, transversic disorder, transversic disorder. Now we let's check the difference between these two. The difference between these two is the nature, harm to self, diagnosis, requires if it requires treatment. You see, the nature is a typical sexual interest is paraphilic, and the other one is a typical plus distress or harm. That one we have seen. Now we got to harm to self. Sometimes in paraphilic there is no, it's not necessary. But when we look at paraphilic disorder, in paraphilia harm is not necessary, but in paraphilic it is necessary. Diagnosis, no, and we have seen the differences since we started. Paraphilia, there is no more, mostly there is no harm, but in paraphilic there is harm. Now let's embark on the topic of the day: sleep-wake disorders. What are sleep-wake disorders? What are the disorders that they may make you sleep and wake up? Sleep-wake disorders. These are group of conditions that involve with the quality, timing, and amount of sleep, resulting in, yes, I can see someone with a very heavy name. What's your name, please? I cannot read those marks. Yes, bro. Welcome to the channel. Welcome to the channel. I'm speaking about sleep-wake disorders. Sleep-wake disorders. Now, you like you at least like the video. Ask a question if you have it as we go on. Yes, we are talking about sleep-wake disorders. Are groups of conditions that involve problems with quality, timing, and amount of sleep, mm, resulting in daytime distress and impairment. Resulting in daytime distress and impairment. These disorders are classified, mm, as follows, and they have categories. mm. They have categories. Let me, I don't know how I can call this one. I cannot read Indian calligraphs, their spelling, so I'll just continue. Now, we continue, we continue. They are classified into insomnia disorder, hypersomnolence disorder, narcolepsy, obstructive sleep apnea, hypnopnea. Obstructive sleep apnea, hypnopnea. You see that? Central sleep apnea. Sleep-related hypoventilation. Sleep-related hypoventilation. You see that? Cardiac sleep wake disorder. Yes, we talked about cardiac breathing. So there is cardiac sleep wake disorder, and then we have non-rapid eye movement sleep wake disorder, non-rapid eye movement sleep wake disorder, and then we have nightmare disorder. Those people that get nightmare disorder. We have rapid eye movement sleep-wake disorder. We have restless leg syndrome, substance and medication-induced sleep-wake disorders. Yes, where do you lie? Hmm? We start with the first one. Those are several sleep-wake disorders. There are some people who have problems when it comes to sleeping. There are some people who have problems when it comes to sleeping, and that's what we're gonna deal with today. You see, uh, uh, when you go and sleep and you are not getting enough sleep, and you spend the whole day the next day, and you are not okay. You see, it is disturbing you mentally. That's why I decided to come with this topic, and we see several issues that will make a person not to sleep well and have stress. In otherwise, it makes a person have what can I call it? It makes a person Santosh. Okay, this guy is called Santosh. Santosh. So we continue, we continue, we continue. Now here we have insomnia. Here we have insomnia. Insomnia is a, a sleep-wake disorder, difficulty in sleeping, staying asleep or waking too early, eh, for at least 3 nights, weeks, and ends up to 3 months or equal to 3 months. But you see, 3 months to is a long period. Hmm? Let's see. Let's talk about this in details. We talk about this in details. We see how insomnia comes and how we can deal with it. Hmm? Insomnia, people lack of sleep. We only know one, which is insomnia, which is lack of real sleep. Insomnia is a sleep-wake disorder characterized by persistent difficulty falling asleep, staying asleep, or waking too early. You only have few hours of sleeping. Addi- Despite adequate opportunity for sleep and causing significant daytime distress or impairment. You see, it causes some significant data distress or impairment. Now, we can say difficult when we want to know this person is having insomnia. What do we look at? We look at difficult initiating sleep, difficult initiating sleep, or difficult in maintaining sleep. When a person has difficult in maintaining sleep, one of the characters, we're talking about sleep-wake disorders. We have seen there are several sleep-wake disorders, and these sleep-wake disorders, they may go up to how many? 9. Hmm? We have talked about several, many sleep-wake disorders, and these ones that cause a person not to have enough sleep. And you know, when you don't have enough sleep, it affects your mental health. We have 12 sleep-wake disorders, people that have problems in sleeping. Please welcome to the channel. Like the video as you go on, and if you have not subscribed, please do it. Now we check on this sleep-wake disorder that is called insomnia. People only know that insomnia is lack of sleep, but how do you know? It is the first one among the 12 problems of getting sleep, because without getting sleep, you have mental issues. Yes, and you may be very sick physically. Welcome, beauty. Yes, Sambwana. Unjani. Unjani. Hope I have spelled it correctly. Unjani. Unjani. Beauty. Welcome. Let me say Unjani. Hope I've said it correctly. Now, when you look at a person and then you know this person has a problem in sleeping, what do you look at? You look at Giafila. Yes. And Unjani means what? Unjani. Okay, Giafila. It's Giafila. It sounds like I'm feeling. I'm okay. Yes. Very nice. Let's go on with the topic of the day. Those people that have problems in sleeping. Early morning awakening with inability to return to sleep. You wake up very early in the morning and you cannot return back to sleep. You see, that is one part of insomnia. Difficulty in maintaining sleep. You go to bed and you can't maintain sleep. You always wake up. This is insomnia. There are three. When we categorize the insomnia, we said one is difficulty to initiate sleep. You cannot sleep when you want. And difficulty in maintaining sleep. And the third, early morning awakening with ability to return to sleep. You get it? And then there is B, which is the sleep disturbance cause clinical significant distress or impairment in social, occupational, education, academic, behavioral, and important areas of function. You go to school, you cannot concentrate because you are tired, you did not have enough sleep. You are at work, you cannot concentrate because You are tired and you are always dozing off because you did not initiate sleep when time was one. This is called insomnia. So for you to say you have insomnia, you really need to have these three. You can't initiate sleep well, you can't maintain sleep, and you wake up very early in the morning. You see that? The sleep difficult occurs at least 3 nights per week. So in a week, if you have the sleep difficulty in 3 nights and persistent, after the 3 nights it comes and goes for 3 months, you know you will have a problem called insomnia. Eh? We have several types. We will see several types of insomnia. The sleep difficulty occurs despite adequate opportunity to sleep. When you have an opportunity to sleep, you can't sleep. Insomnia is not better explained by and does not occur exclusively during cause of sleep wake disorder. You get it? Now, we have several types of insomnia like acute insomnia, which is at least 1 month due to stress, travel, or illness. Sometimes when you are stressed, you cannot sleep well. When you are sick, you cannot sleep well, or some illness has come and it's causing so much pain, it will change your sleep pattern. We have chronic insomnia for at least 3 months or more. You get it? And then primary insomnia, which occurs independently of other health issues. It just comes. You don't have any health issues or any problem, but this thing just comes. Comorbid insomnia occurs with psychiatric or medical condition like depression and chronic pain. With that one, we call comorbid insomnia. So there are three: acute insomnia, chronic insomnia, primary insomnia, comorbid insomnia. So when you have sleep problems and you don't have a problem, just know you have primary insomnia. Yes, for the four. Now, symptoms, we have talked about them. We have talked about mood disturbance, reduction, performance at work, all those we have talked about. But you see that some people that have risk in getting insomnia, old age, when you're getting old, sleep becomes a problem, and we know that all of us, we know that all of us. We have female genders. Yes, because of more hormones that disturb. Female genders are at risk. Stress related, those people that are stressed, perfectionists. Perfectionist, if you know your character is a perfectionist, you go on a personalities disorder, you will see a perfectionist there on our video. You will know you are at risk. Poor sleep habits, irregular sleep schedules. You can sleep at 3, you wake up at 6, you sleep at night at 12. It's a problem. A psychiatric condition like anxiety and depression can cause you to have insomnia. You see, now female gender, old age, stress, poor sleep habits, psychiatric condition, chronic pain or medication illness, you see, or medical illness, shift work or frequent travels. The people that travels, they have a problem with this because when you want to board a plane, you have sleep and it's not there. You cannot sleep until it comes. You are traveling always, disturbances. Now, we will go on to see the other one before we start to know how to treat because most of them are treated the same way. Sleep hygiene recommendation, maintain a constant sleep wake pattern, avoid screens. At times we keep our children on TVs for long and phones. Avoid that. Use caffeine and heavy meals before bed. Avoid taking heavy meals before bed. You'll have a problem sleeping. Even coffee. Yes. Hey, my Tennessee Sky, the name that I usually had to to spell. My Tennessee Sky. Welcome. Yes, welcome everyone. Welcome. Today we are talking about sleep wake uh, disorders. Sleep wake disorders. Use the bed only for sleep. Use the bed only for sleep and sex. Yeah, these guys, the DSM-5 reviewers were fine. Yes, get out of bed if not asleep within 20 to 30 minutes. You get it? Don't stay in bed. If you know you have a problem in insomnia, wake up, Within 20 minutes, you should be out of bed. It will help you to have that pattern. Your brain will have that pattern. Now, we go to cognitive behavior therapy in insomnia. Cognitive behavior, gold standard. This is the gold standard to help you when you are with a problem. You see, we associate bed with sleep, stimuli control. When you associate bed with sleep and bed with going to relax without sleep is a problem. But associate bed with sleep. Please like the video as you are in the platform as you continue. Yes, yes. I have coffee. I drink it every day, even at night. Hi there. Hey, Julie, welcome to the family. Today we are talking about sleep-wake disorders. Beauty, don't take coffee when you want to. Minage in the house. Yeah, greeting Benjamin. Minage, do you have insomnia? Beauty, don't take coffee when you're going to sleep. You'll have a problem. It is not okay. Welcome to the platform. We are talking about sleep-wake disorders. We have started with insomnia, and when you have insomnia, this was what you should do: stimulus control, sleep restriction therapy, cognitive restructuring, challenging belief and anxiety before sleep. As you come in the platform, and you have not subscribed, please subscribe. Hit that subscription button so that when we are online, you can notice that the wise guy is online. Let me see what he's talking about. Very nice. And you see, everything that I talk about can help a person out there. So, subscribe, and we go on. If you have an idea of what I'm talking about or an experience, please tell me. If you have a good experience, let's discuss it as we go on. Now, medication part, I'll not go to it on insomnia because it is coming. Yes. Sleep wake. Now, after insomnia, which is lack of sleep, we have another problem with sleep that is called hypersomnolence disorder. Hypersomnolence disorder. Now, insomnia is not just a problem in sleep pattern and sleep problem. Hypersomnolence disorder is one. Remember, we have 12 of them. Hypersomnolence disorder. What is hypersomnolence disorder? Hypersomnolence disorder is a sleep-wake disorder characterized by excessive sleepiness despite adequate or even prolonged late sleep at night. Imagine when you always feel sleepy, you are always sleepy. Eh? The individual experience difficulty staying awake during the day. Eh? You at daytime, you are having difficulty in staying awake, leading to unintentional sleeping episode naps or dozing off. Have you ever been with someone who is? I went to school with someone who was like that, always sleepy, always sleepy. He was suffering from this disorder, hypersomnolence disorder, as it is said, characterized by excessive sleepiness despite adequate or prolonged sleep. You have slept at night and in the daytime you are still having the problem. So how can you know person has this problem? You see, self-reported excessive sleepiness. Someone can say I always, in Kiswahili we say mimi nakuanga na usingizi kila saa. I'm always having sleepy. A person may say that I'm always feeling sleepy and having sleepy episodes. Yeah, I mean sleepy period, which is 7 hours or less. Imagine you have a sleepy period of 7 hours or less with at least one of the following: recurrent sleep or relapse in sleep within the same day. You have 7 hours, 8 hours of sleep, but you have an episode of sleep during the same day. A prolonged main sleepy episode of more than 9 hours, that is non-restorative, and freshening. It is not freshening you. Difficulty being awake about abrupt awakening, sleep inertly. You see, you're having difficulty in staying fully awake. Sleep inertia, sleep drunkenness. Someone is just drunk in sleep. The hypersomnolence occurs at 3 times a week or 3 months. So if it comes 3 times a week or 3 months, it is a problem. Hmm? You see, significant distress can come in when you have these issues because you cannot work well. You are always distracted with sleep. Eh? Sleep disorders. That is the second sleep disorder. It is not due to substance abuse, including medication. You just have a problem. We will see what comes in with this, not attributed to any mental condition. And you see, hypersomnolence it categorized into three: mild, moderate, uh, mild, moderate. Coffee is good. Hi, Cherono. We are talking about sleep disorders. Cherono, welcome to the family, and like the videos if you are watching and share it out. You don't stop taking coffee, beauty. Just don't take it some hours before sleep, because coffee is a stimulant. It will make you not get coffee. You see, now we see mild is difficulty in maintaining sleep between 1 to 2 days. Yeah? Moderate is difficult 3 to 4 days, and severe is difficult almost daily. Moderate is 3 to 4 days. Mild is between 1 to 2 days. Severe is difficult. You see, very fun. And yes, yes, women facing menopause, there was sleep disorders. We are coming to that. We have 12 types of sleep disorders. We are just at the second one. And we've seen in Julie, we have seen in insomnia, old age is a problem because of the changing of hormones. Now, evaluation sleep diary log for 1 week. When you want to at least to help yourself, sleep diary log for 1 to 2 weeks. Put a diary of sleep. Epworth sleeping scale. These are things that we use and we give patients. Polysomnography, sleep study. Sleep study, they help. These are done in the hospital. Multiple sleep tendency test. Treatment is behavioral intervention, very important. Very important. You see that? But there is something called pathophysiology. Physiology. This is how pathophysiology means how this problem comes. But you see, in hypersomnolence, the exact physiology of hypersomnolence disorder is also called idiopathic hypersomnia. It's not fully understood, but it's believed to involve dysregulation of brain system responding to sleep and homeostasis. So it is not fully understood, but at times these are the things. The ascending arousal system, which is dopamine, norepinephrine, and histamine hypercentrine, are related. So neurotransmitters are related. Sleep neurotransmitters. So we have seen insomnia and hypersomnolence, they are different. So we go to the third one, which is narcolepsy. Narcolepsy. What is narcolepsy? We have started with insomnia, and then we have gone to hypersomnolence. So narcolepsy, what is narcolepsy? If you have a question, please you just raise it up and we discuss. We discuss on the platform. It is very important. You may be having a question that is helping yourself and help other people too. Now, narcolepsy is a chronic neurological sleep disorder characterized by Herbs and Spice Kitchen. Yes, blessings, blessings. Welcome, welcome. Like the video, and we continue. We see how sleep disorders are affecting and what are sleep disorders. Now, narcolepsy is a sleep disorder just like insomnia and hypersomnolence. Now, narcolepsy is a chronic neurological sleep. Yes, Michael N., welcome to the platform. Welcome. We are talking about sleep disorders. Sleep disorders, man, characterized by excessive daytime sleepiness and recurrent episode of sudden sleep attacks. Narcolepsy. is a chronic neurological brain problem characterized by excessive daytime sleepiness and recurrent episode. When you have daytime problems and then you have sudden episode when you just sleep, you just there and then suddenly you sleep, often accompanied by abnormal REM sleep phenomena like cataplexy, hallucinations, or sleep paralysis. You if do anyone know what sleep paralysis is? If you have ever encountered sleep paralysis, it's not a good thing. Sleep paralysis, you may feel that there are some other powers that are regulating your body, but it is called sleep paralysis. You are awake in sleep, but you cannot move. And then there is hallucinations, hallucinating in sleep. People that hallucinate in sleep, and cataplexy. These are in narcolepsy. Contrary to insomnia and contrary to insomnia and hypersomnolence. In these two, there is no hallucinations and sleep. You see, it results from dysfunction of brain's ability to regulate sleep cycles. You have problems in regulating sleep cycles, particularly the REM sleep phenomenon, the one that controls you to sleep, wake up, and now one things that may make you know that you are having narcolepsy. One is cataplexy, sudden loss of muscle tone. Cataplexy, when you are sleeping, you want to wake up and you can't wake up. You cannot. Your muscles are so tired. Your muscles are so weak. It is called cataplexy. It's often triggered by emotions like laughter, occurring at least 5 times per month. In 5 times per month, when you have cataplexy, you know you're heading to have this problem of narcolepsy. Hypocretin, oryx deficiency. Hypocretin measured via CSFs. When someone has meningitis, we do spine injection. We get some fluid from the spine. It's called CSF, cerebral spinal fluid. So that is what we look at so that we can know the brain is having a problem. Now, hypocretin also we look at the same way. You see, so when it is less than 110, we know this guy has this problem. Polysomnography, sonomonography, and MLST, multiple sleep latency tests. These are tests that are done in hospital to know that this person has narcolepsy, because narcolepsy, while you are asleep, you have problems in movement. You cannot move your muscles. You are like, you have paralysis, but it is sudden and with time. But it can occur within 5 months, so that we know this person has this sleep problem. When you sleep, you have sleep paralysis. Anyone here who has had sleep paralysis, you give us how you felt. Anyone, how you felt, because sleep paralysis is it's a bad situation, I know. Now, narcolepsy, there are two types. There are type 1 and 2. Often hypocretin deficiency, that hypocretin, when we take the cerebrospinal fluid from the spine and then we check and then we see it is down. Yes, yes, Michael N. Michael N cerebrospinal fluid, we take it and we look at hypocretin. We know this person, Karen White, welcome. We are talking about sleep disorders. We are talking about sleep disorders. And share the video today so that we may help some people out there. Now we have, when hypocretin is deficiency, if someone has hypocretin deficiency, we know this one has this problem. And in type 2, you have the sleep paralysis problem, but the hypocretin is okay. Hmm? Have you ever have you ever had sleep paralysis? Imagine you are sleeping and then you feel that someone is walking around your compound, but you cannot wake up because you feel when you want to raise your hand, it cannot. you have sleep paralysis. It's normal to people that have this hormone called hypocretin deficiency, and this one is we will know this person has narcolepsy. Now, cause symptoms are cataplexy, hypno, hypnogic hallucinations, and then excessive daytime sleeping. You sleep a lot, and sleep paralysis and sleep disruptions. When you have these ones, we know this person has this problem. Loss of pathophysiology, we have told. Pathophysiology is how these things happen, like loss of hypocretin. The sleep pattern has a problem, believed to autoimmune. Now we go on, we will talk about these treatments, like treatment of narcolepsy, excessive daytime, modafinil and amlodipine, fast wake promoting agents. So modafinil is a tablet that helps you stay awake. Methylphenidate and amphetamine, traditional stimulants, have more side effects. You will be fat when you use these drugs. Let me just say you will increase in body size. So don't use methylphenidates and amphetamines. You better use modafinil to stay awake. Cataplexy, if it is down, use sodium oxybate to increase. And then we have valencyphine as serotonin inhibitors. Now we continue. Today we have several sleep disorders, up to 12 sleep disorders. One is insomnia, second is hypersomnolence, we are in the third, which is narcolepsy. And then we have the fourth, which is obstructive sleep apnea, hypnopnea. Imagine that, obstructive. You're just sleeping and you are obstructed. This is a very complicated issue when it comes to people who have these problems, brain problems. You get it? Brain problems. Obstructive sleep hypnomnia is a breathing related sleep disorder. It is sleep related disorder characterized by recurrent episode of upper airway obstruction. You are sleeping, that then you just start losing air because you are obstructed from your nose to your throat. There is something that is obstructing you. If you have an experience, please raise it up. Let's talk about it. Yes, because we are at the fourth one. During sleep, you are interrupted. Sleep and oxygen desaturation. Your oxygens go down. Often daytime sleeping or fatigue, mostly at daytime. Now, how can we say this person has obstructive sleep apnea, hypnopnea? How can we say? One, nocturnal breathing disturbance, snoring. The people that snore, wah, wah. Imagine you have a partner and that partner is snoring, just snoring at night, or breathing pauses. We have had even those people that pause while they are breathing. Even kids, small kids are proud of this. So you see nocturnal breathing disturbance by snoring, gasping, or breathing pauses. And then we have daytime sleepiness, fatigue, or unrefreshing sleep despite adequate opportunity to sleep. Hmm? Daytime sleepiness and fatigue. Or the second one that may make us know that this person has sleep disturbance, evidenced by polymorphography, the one that we do in hospital. Yeah, you get at least 15 obstructive apneas or hypnopnea per hour of sleep. Regardless of associated symptom, we know you have a problem. Severity based on hypnopnea index. Those are things. Hypnopnea index is whatever that makes us categorize these sleep problems. Like from 5 to 14, that is mild, and then 15 to 29, that is moderate. If you have 30, you have severe. That is where you are given those masks to sleep with, because you may die in sleep, because lack of oxygen may lead to your brain lacking oxygen. So if it is severe, you are given the mask to help you to sleep. Yeah, at night, these people, you may feel them loud, snoring so loud gasping or choking during sleep, observed apneas, you get it, frequent awakening or restlessness in sleep. Hmm? Nocturia, frequent urination at night, it's a problem. If you are always waking up at night and you are having nocturia, nocturia is waking up at night to go to relieve yourself. And in daytime, excessive daytime sleepiness, morning headaches. You have headaches because you have not slept well. And then poor concentration or memory issues, irritability or mood disturbance, dry mouth or sore throat on waking up. Because so you know when you snore, your mouth is open, bacteria go to your throat, and then you get a sore throat. This is the pathophysiology. This is the problem that comes out with people that snore or you sleep while your mouth is open. You get sore throats because now bacteria enter your throat. Remember to ask any question, even if it is medical or what. Your question is very significant to us because it will help someone other person. Now, this is how snoring and sleep wake disturbance comes out. Disruptive, how obstructive sleep wake disturbance come out. During sleep, muscle tone in the upper airway, here upper airway, decreases. The tone, the muscles are supposed to be stiff, but they decrease in tone. So in susceptible individuals, those people that are prone to this, either those with obesity or narrow airway, the people that are obesity, they have huge bodies and their necks are big, and those with narrow airways, this leads to airway collapse. Now, the airway collapse, let's say this is an airway, whatever you are seeing is an airway. Collapsing is like this. Now, if it collapses, it becomes like a funnel. So when you breathe in, it beats and open like this. That is how, like that one. So snoring comes out like this. It's like the flute, how you blow your flute and then it does whoo. So it comes whoo, like that. That is how the airway collapse for those people that are big or having small airway to the lungs. You see, repeated airflow obstruction in ends to intermittent hypoxia. Hypoxia is lack of oxygen, lack of air, arousal, fragmental sleep. You always wake up because now when you lack oxygen, you wake up and sympathetic activations go down. The normal system goes down. Long-term consequences include those people that have this sleep obstruction, they have long-term consequences like hypertension, cardiovascular disease, insulin resistance. So when you have insulin resistance, diabetes comes in. You get it? Because now you have less insulin to beat up the sugars that you are having in your body. And then you have cognitive decline. The IQ goes down. You start doing things without the normal procedures. People say you are not smart anymore nowadays because of these sleep disorders that you're having. So if you have someone who have obstructive sleep disorder because of being obese or your partner is snoring so much at night, let the partner see a doctor so that he can be diagnosed and then he can be given some pills or some things to help the airway. You see, now who are at risk at this obstructive risk disorder? Anatomically, obesity people, large tonsil nodes, thick, 17 inches in men and 16 in women. You see, those are big tonsil nodes. You get it? Thick neck, thick neck. When you have thick neck, that is a problem. Reduced pharyngeal tone during muscles in your throat if they have a problem. Lifestyle, people that love alcohol. I usually say for me, alcohol, I may take it occasionally. I don't drink alcohol, but excessive taking of alcohol is harmful to your life. Alcohol is not bad. The bad thing is Whoever takes alcohol excessively, you take alcohol like there is no tomorrow, and then you'll be drunk so much. You see, it may bring you this problem. Eh? Smoking is something that is very bad. That one, it brings cancers, problems, star in your stomach, is associated with very many complications. And then sedatives, the people that use sedatives. Sedatives are those people, things that may make you sleep. We use them mostly on in theaters for doing procedures. But you see, they are muscle relaxants and they make your muscle collapse. So you may have nasal flarings and snoring. So it is not good to use sedatives when you are sleeping. It will You may die on sleep because of lack of oxygen. Because now the problem is what? The problem is you are not passing on air well. Others like male sex. Male sex are prone to snoring. We know that male sex are prone to snoring because of their large airway and muscles in the throat. Too old age, again, because of muscle relaxations at old age and family history. Treatment: continuous positive airway pressure. Keep airway open during sleep. Most effective therapy, moderate to OS. Alternative therapies: oral application, mandibular devices, the one we put. There are some things we put for you, a cup, so that you may sleep with it. You get one. That one is your doctor. When you go to a doctor, he'll decide what to do. But obstructive sleep disorder is a bad problem in this way. It may cause hypertension, stroke because of lack of oxygen in your brain, atrial fibrillation, your heart may get palpitations, myocardial infarction. Myocardial are heart muscles, so when they are not getting oxygen, they may die. You see? And then you may get that diabetes type 2. You get because of insulin resistance type 2. You are not getting enough oxygen, and then your IQ may go down. And then of course, depression, because you are thinking how to make up with this. Now we go to the next one, which is central sleep apnea. Central sleep apnea. What do you think about when we are talking about central sleep apnea? This is apnea is lack of air. So central sleep apnea is characterized. Central, we talk about the centers of sleep in your brain. You see, the centers of sleep in your brain. So, what are we talking about when we talk about central sleep apnea? Just a minute. Just a minute. I tell this one someone. Yeah, central sleep apnea. Central sleep apnea is related breathing disorder characterized by repeated episodes of cessation of breathing. Imagine you are sleeping and then you stop breathing, caused by lack of respiratory effort rather than physical obstruction. This is due to dysfunction in the brain respiratory centers leading to impairment. There is a problem in your brain, and that problem is what is making you not to breathe while sleeping. Hmm? Imagine. Hmm. This one is mostly brought by neurotransmitters in the brain. So we may categorize them as idiopathic. We don't know what is bringing them. And then we categorize them as chain stop breathing. This one, chain stop breathing, the second one, is common in heart failure and stroke. Those people that have got stroke can get that problem. Eh? CSA due to chain stop breathing due to altitude periodic breathing. Eh? Altitude periodic breathing, temporary sleeping at high altitude. You have just come from the US, you are coming to Africa, and then you are undergoing this. You get it? And then you are undergoing this. Altitude may make you have this. And then we have due to medication or substance. Some people may face it due to medication and other substance. And then treatment emergence CAS. Sometimes you may undergo some treatment and some surgeries, and they make you have this. Now, how can we know this person has central problem. Like we can have fatigue, poor concentration, morning headaches, moods, and mood changes. Night symptoms at night, weakness, apneas, awakening with such breath or breathing, restless sleep, insomnia, and frequent arousal. Imagine insomnia at night. Mm? Uh, the pathophysiology, you have said most of them they are not known. Instability in feedback in the brainstem. Causes may involve hypersensitive chemoreceptors, delayed circulatory tone, neurologic injury, stroke, and tumors in your brain can make you have this problem. Trauma, you hit your head and then you start having sleep problems. You will know you have a problem in brain centers of sleep. Hmm? We will see the diagnosis is always the same. Let's go. We have the sixth one, which is sleep related hypoventilation. What do you know about hypoventilation? Sleep related hypoventilation. You are just sleeping and you are not well ventilated. Hmm? You are just sleeping and you are not well ventilated. You see, we are talking about 6 to 12 types of sleep disorders. So hypoventilation is a disorder in sleep. Sleep-related hypoventilation is a breathing disorder characterized by inadequate ventilation, reduced airflow, and gas in exchange during sleep, leading to elevated arterial CO2. Your carbon dioxide goes up. Hmm? So this one, what brings it? Blunted central chemoreceptors response to CO2. Sometimes you make a lot of carbon dioxide to your body that makes you reduce oxygen. Impaired respiratory muscles function in your throat from the mouth. You don't have good muscles that will help you breathe well. Central wall abnormalities, central chest wall abnormalities. Those people that have chest problems, asthmatic people, COPD people, those people that are asthmatic are having a problem because of their hypersensitivity to several things, obesity or neuromuscular conditions. You see, obesity always comes in, so it's good to be physically fit. Having a big body does not mean you are obesity. Let me say that clearly. You may see a person having a big body, but that person is not obese because the body mass index is related to the height. You understand, is okay. So it means this person is just having a big body, but physiologically he is okay. Eh? But the problem with these things may lead to hypoventilation, lack of oxygen, and times you have a problem in breathing. So how can we categorize this sleep related hypoventilation? Idiopathic, sometimes you don't know, it's not clear. Someone is just okay, but you go do an MRI, everything is okay, but we cannot say he has this problem. We have congenital central hypoventilation, mutation in genes. This one is in family. There is a gene called PHOX2B gene that helps you to have good muscles of respiratory surface. But now in your family you have that mutated gene that is carried over to other family line. This is a problem. Hypoventilation due to medical disorder like muscular diseases, muscular dystrophy, ALS, kyphoscoliosis, those people that have back problems that have gone like this, or hypothyroidism. The people with thyroid problem may have problems with sleeping. Obesity, hypoventilation, sleeping. Obesity is one of the problem. So if a person is, you see, you have a friend that is heading to obesity, talk to that person to go to work out, be physically fit, regulate eating habits so that this person cannot get this problem. Yes, there are many sleep problems that you see, every sleep problem that I'm mentioning is related to obesity. So let us regulate our health issues like foods we eat and exercise. Very important. Let's not overeat something saying we are making us healthy. Let's, if you don't know about nutrition, ask about the good, how you can be nutritionally well. It's not a must that you have a lot of money so that you eat well. No, some people have money, but they don't know how to eat. You see, some people have money, but they are using the money to make themselves sick. When you have money, but you're making yourself sick by the money, please, you are a problem to yourself. Have the money, have the finances, hit the gym, eat well. Eating well does not mean eating a lot of carbs. Eating well does not mean eating a lot of junk food. I think we will come here one day and discuss how to eat well, how to eat well when you have moderate financial income. Because wherever you are, everywhere in this country, there are some things that you can eat and have a balanced nutritional diet. But when you talk to someone and tell someone now, I want you to have a balanced nutritional diet, this person will tell you, I don't have money to do that. I think that topic will come. Let's set it so that we discuss about balanced nutritional diet. Even for we avoid obesity and other problems that may come with other things. Our body is the temple and God wants us to take care of it. Yes, very well. Explore with Anne. Welcome, Explore with Anne. Explore with Anne is a cousin to Jamaican uncle. Yes, yes, yes. Explore with Anne. And that's why I took this responsibility to help people to keep their body as the temple of Christ. Today we are talking about sleep-wake disorders. Let's not go so much into that. That day will come. I'll talk about nutrition with the. I'll talk about nutrition with standard financing. Yes, because when you tell people to eat well, what they think about always is I don't have money. I've get clients in my office, several clients. When you tell them please adjust your nutrition, they tell you, I doctor, I don't how to eat well with moderate financing. Now we are at the sixth problem of sleep-wake disorders. There is the seventh one. The seventh one is called circadian sleep, circadian sleep rhythm disorders. Circadian. You see, there are so many things. I've talked to that about because of obesity, because so many people are having a problem with obesity. Every sleep disorder that we are seeing here is coming with obesity. That's why I've talked a lot about it. Now, circadian, we are in circadian rhythm sleep wake disorder. What is circadian? We talked about it at at the brain centers when I was introducing the brain. Eh? When I was introducing the brain. Hmm? This is a rhythm work disorder. Circadian sleep work are group of sleep disorder caused by misalignment between person biological clock. You know, you have a clock of sleeping and external environment, e.g., social demand, light dark cycle. This leads to insomnia, excessive sleepiness, or both. You are used to sleep when the lights are off, but someone comes and puts them on and you become awake. Eh? What is circadian rhythm? A 24-hour internal clock that regulates sleep wake cycle, body temperature, hormone release, how you release hormone. You know, the melatonin hormone is what makes you have sleep. Melatonin hormone is what makes you have sleep. And then there is cortisol, which is a steroid that wakes you up, controlled by suprachiasmatic stimulus. There is something called suprachiasmatic stimuli in your brain that controls it. in the hypothalamus. You check it, the midbrain, somewhere here inside in the hypothalamus, influenced by light, social cues, and activity. It is like the sensor of the car, the current cars. When there is rain, it's practically, when the rain touches the windscreen, it practically starts the windscreen. You get it. So in people, the circadian rhythm is like that. When darkness come, after 2 hours you start feeling to sleep, because it has the darkness activates it. The darkness activates it. But you may have a problem with this circadian rhythm. You see, these are the problems that come when it comes to circadian rhythm. Delayed sleep-wake phase disorder. You stay so long watching TV because you like that movie. You go to party after party. You sleep late at 3. You see, sleep delayed by 2 hours or more. Hmm? You see, teens, young adults, night owls. Teens are prone to this because of watching movies overnight. And there is advanced sleep phase disorder, advanced sleep-wake disorder. You wake up early than desired. You see, older people have a problem in this. Irregular sleep-wake rhythm. These are the things that will make you have this problem. Shift work disorders, jet lag disorders. You get it? These are the problems. So, by the way, as we talk about these things, you should relate them with issues that happen in families. You always say maybe your grandmother or your mom or your dad or your brother is diabetic, but you have not thought about the mode of work that your brother, your mother, or your sister is doing. You find someone is a DJ and this person is diabetic. Think about the sleep pattern. Think about the sleep pattern. Why? Because resistance to sleep may cause insulin resistance and you become diabetic. So if you have problems like hypertension and hyperthyroidism and diabetes in the family, please at times look at the common things like sleep patterns. They may end up someone having thyroid function problems and at times diabetes. You get it? You are thinking it's a genetic thing, you are taking so many drugs for so long, and you see the problem is yourself, sleep patterns. Because everywhere you see, for all those sleep problems that we have been talking about, diabetes is there, and then there is obesity is there. So let's relate these issues and at least settle them for less. Like this, if you have enough sleep and good mental health, you will not get insulin resistance. So you will save the money to buy drugs for diabetes. You will save the money to buy drugs for hypertension. You get it? So at times, let's not go deep. You go to a doctor, you have done so many tests. You have done thyroid test, you have done kidney function test, you have done all those liver function tests. You lose a lot of finances, you pay your insurance just because your work and sleep patterns is a problem. At times we need to to look beyond whatever we think. If someone has said here, explore with Anne, our body is the temple and God wants us to take care of it. Please let's take care of our bodies. Let's not change nature to something that we cannot. Let's sleep, have rest, have good mental health. Let's stay within our means. Let's not stress ourselves to some things that we cannot have with time. So that we have good mental health. We don't want people to be diabetic. Hmm? We don't want, I have two siblings who is diabetic. Just imagine, explore that, talk to them, check very little things that I'm a doctor or a medical practitioner or a health worker. Look around where you are. Are these small things that are bringing insulin resistance, that are making people big diabetic? Is it mental health that is disturbing this person? Ask yourself that. You see, we have talked about sleep problems that are up to 7. We are at the seventh one or sixth, but we are talking about two specific things: diabetes, hypertension, and the other one, hmm? Mental health. Now we continue. Clinical features of this cardiac rhythm sleep disorder is insomnia, excessive sleepiness, fatigue, mood changes, and poor concentration. Yeah? The other things that we have talked about, we've seen how we differentiate them, the ones that we have come. Now, pathophysiology, how does this come? Circadian misalignment between endogenous rhythm and external environment. Endogenous rhythm is inside you and external environment is outside. So how the light comes, the clock of your body senses it is dark, I need to sleep. But nowadays it is the reverse. Some people, when darkness come, yes, it is time, I need to go out. You are disturbing your circadian rhythm because God created us to rest at night and wake up in the morning so that we see what is happening and work well. But at night you cannot see what is happening well. We saw that that's why we use artificial light for like 2 hours. Then the circadian rhythm takes place and you sleep. Hmm? In subtypes, the body does not naturally entrain to a 24-hour cycle. You cannot. If a person sleeps for more than 24 hours, know that person has a problem. Hmm? You see, treatment is delayed. Phase light therapy is important, and first phase light therapy in the evening. Irregular, you structure routine. Non 24 hours. Tesminoton, melatonin at bedtime. Those are drugs that you can take and get sleep. Shift work disorder. Do work wherever you are. It's supposed to be done. Jet lag. Behavioral intervention, very important. Chronotherapy, gradual adjustment to light. Cognitive behavior therapy, you see, very important. Cognitive, we are still talking about cognitive behavior therapy. Now, we are at the eighth one. We have so many sleep patterns. Today, we have to finish up to 12. Non-rapid Non-rapid movement sleep arousal disorder. Non-rapid movement sleep arousal disorder. Yes, people, my family, we are talking these things so that you see the reason why I'm coming up with this. The reason why I've decided to come to YouTube and talk about some things, it's because of this. I've noticed some people suffer from complicated diseases, chronic diseases, because of neglecting several small things, several small issues. And you see, when I decided to come with speak out and share these ideas, I categorically saw every chronic issues that we face, they are related to our brain. And this brain of ours is our mental health program. Be it you are a professional, be it you are a child, be it you are a person who is at a standard class in life, be it you are what. There is a book I read that is called Walenisi that was talking to, it is written in Swahili, and this person was saying that every person is a person. Be it you are an engineer, a doctor, or a nursery school who did ECD, you are doing a great job to the universe. So the difference in salary schemes is not a good thing because we all suffer the same problems and how we relate to them is equal to how our brains function. Because a person who, let me say, a politician who is a member of parliament or a president suffers from problems of borrowing a lot of money. And I'm an ECD teacher or a person who is under normal level of life. I've borrowed, let me say, $4, and I cannot pay it back because I don't earn enough to pay those $4. The problem I'm having is equal to that of that member of parliament or the president who borrowed a lot of money and cannot pay it back. So mental issues in life is a standard mode. Hmm? We relate to it as us being at the level where we know if we live like this, we will live a good life, accepting and trying to change to the best so that our brain health cannot be destroyed. Hmm? So let's share everything, let's relate. Let's not be in a struggle to be what we are not. Hmm? We are talking. Oh, sorry, I've gone off page. I'm just talking. I'm just talking. If you have experience, please relate it to us. Let's go on. We are talking to non-rapid eye movement, the eighth one, non-rapid eye movement sleep arousal disorder. Sometimes I get carried away and I start talking to things that I'm not supposed out of topic, but you, you we will catch up. Yes, forgive me for that. If you feel whatever I'm saying is not correct, please tell me, Dr. Ben, that is not correct. I'll accept what I'm talking is not correct. But let's go to the topic of the day, where non-rapid eye movement, sleep arousal disorder, non-rapid sleep. You see, are parasomnias, undesired physical or behavioral events. They are undesired physical or behavioral events. This one is a sleep disorder that is not is a funny behavioral event in sleeping. Hmm? Marjay in the house. Dr. B, yes, I'm here. Hi, everyone. Marjay, we are talking about sleep disorders. We are at the eighth one. As we finish, you start the video from the beginning. You will learn a lot. Like my video, subscribe if you have not subscribed, exchange, share. Let people know that here we talk about mental health and other diseases, and we help each other to know how to cope with issues. I'll one day start bringing professionals. You hear from them so that it's not me alone. If it is gynecologic issues, I look for a gynac to come and talk to you. If it's a pediatric issue, another colleague of mine who is a pediatrician that day to come and talk to you. But if you have a question for now, just relate, ask. We may exchange notes and then we are good. Now, we are at non-rapid. These are not good things. Non-rapid eye movement, sleep arousal disorder. These disorders involve partial arousal from deep sleep with limited awareness of no recall of the episode. Eh? Imagine, non-rapid sleep arousal disorder are parasomnias. Parasomnias are, yes, beauty, you are here, undesired physical or behavioral events while you are sleeping. Sleepwalking is one of them. We call it somnambulism. Sleepwalking is. Have everyone come across a person who does sleepwalking? Ask that person after that day. Ask that person after that day. You will find that these people will not realize that they sleepwalked. You see, you are sleeping, rising from bed and walking around with a blank, staring face, unresponsive to others, and difficulty awakening. You are walking while sleeping. and even your eyes are awake. Your eyes are awake. So sleepwalking is one of them. Non-rapid eye movement is one of them. Sleep terrors, night terrors. You are sleeping, sudden arousal with panic and scream. Have you ever been with someone in a room like that one, in a house? A person, you are just sleeping well and someone wakes, aroused, screams, intense fear comes in, automatical arousal, tachycardia, your heart beats so fast and sweating comes in, and unresponsive to calm infant. When people tell you please calm down, you cannot calm because remember you are sleeping. So this is sleep. These two, sleepwalking and sleep terrors, are under non-rapid eye movement sleep arousal disorders. Sleepwalking and sleep terrors. Eh? Now, you see, you no or little, you will find someone has no or little, only one word. Dream imaginary is recalled. Whatever you are dreaming and talking about is what you will speak. But if you are talked to, you will not respond. Amnesia for the episode is present. Imagine. The episode can cause clinical distress, sometimes even physical issues in social, occupational. You go to work, you start being stressed because people are looking at you at home and you cannot recall what you did. When they ask you, what did you do last time? Please, people, when you meet someone who has a sleepwalk disorder, like sleepwalking and sleep terror, don't ask them what they did last time. How you can help, take these people to a professional. If you start asking these people what did you do last time, you are torturing them. Talk to them well, tell them you need to see a doctor, take this person to a doctor, let this person see a doctor, so that a doctor, a psychiatrist can know how to take this issue up. Don't stress these people. Don't tell them they're having bad spirits. I've heard some people say that those people that sleepwalk, they have bad spirits. No, it's not bad spirits. It is sometimes their brain function has a problem. Neurotransmitters are not okay. So they need to see a doctor to take them, to make them be well. Sleepwalking. You see, terror at night. It's not a good experience. It's not a good experience. So let's not stigmatize them. Let's not stigmatize these people. Please, people, I'm just going through this, and I know you have a lot of questions that you need to ask. If you have a question, put it across, or if it is private, my email address, I think people have them. benjaokwesh@yahoo.com. Email me at that. I'll be able to help you. I'll be able to guide you, and at least you live better. Now, what is the pathophysiology? What brings this sleepwalking and horrors at night? Okay, slowly wave sleep, especially in the night, results in incomplete arousal. The brain is partially awake and partially asleep. Immature and stable arousal system in the brain can cause partial awakening. Contributing factor, genetic disposition. If you have this problem in your family, maybe a brain problem in your family, you don't give yourself enough sleep. Stress and anxiety, we talked about anxiety last time. Fever in children. Insomnia, yes, Benjamin. Insomnia, Benjamin. Caron White, yes. We have talked about insomnia. So insomnia, Caron White, is just part of these problems. You see, insomnia is just one part of this problem, because we have named up to 8. Here we are at the 8th one, insomnia. We have talked about how insomnia can bring diabetes, hypersomnolence, how it can bring. You see, Sometimes when a child has fever and it gets to 40 degrees, here in Kenya we use degrees Celsius. In US and other countries they use Fahrenheit. It gets above 101 Fahrenheit or 120 Fahrenheit. You see, that child will convulse, and convulsion may bring brain disturbance. This child may start having these sleep-wake disorders and disturbances of shock at night and terrors at night. Alcohol or sedative use. We are still talking about alcohol. I usually say alcohol is not bad, but overusing alcohol is a bad thing. Let's not overuse alcohol. Let's just drink, feel good. Yeah, take two bottles, take one bottle if you need it, and you'll be good. But if you are healthy, your health does not allow you to take alcohol. Maybe your family, you have a problem related to gout arthritis and you're taking alcohol, you are killing yourself slowly. Discipline yourself. Just take one cup, one beer, eat well, be good. And those people who do not take alcohol, don't try. Don't try and take a lot of alcohol and and you've never taken alcohol, my friend. You will see skies with your feet. And then your liver will damage because of once you have never taken alcohol and then you take a lot of alcohol, your liver cannot contain the alcohol. What will you do? You will walk with your hands, not your legs, and then the alcohol will go to your liver. What will it do? You will start having you will start having you will start having liver function, liver cirrhosis, and then you will have, because the alcohol destroys liver cells, and then the liver cells, they bring fatty liver. That then then the fatty liver brings us to any Christian on here to help me say no to that. I say no. I say no because I don't take alcohol. I don't take alcohol. I'm just advising those people who love alcohol. And then when you get fatty liver, what happens? What happens is this. You start having liver cancer with yellowness of the eyes always. Yes, Michael N is remembering the days in campus. Yes, I can remember. I can relate that. I can relate. Yes, yes, yes. Yes, yes. We go on. Alcohol and sedatives are not good. It contributes to this problem of sleep apnea. And even certain medication like hypnotics and antipsychotics. So, age, gender, and cause may relate to these problems. And there are so many things we are talking about. They are very serious issues. We laugh at them, but we should take them serious. And we at times it's good to have sleep hygiene, reassurance and education, safety precaution, very important. Lock windows, remove sharp objects, because if a person wakes up and is sleepwalking and he has a sharp object and is dreaming about fighting someone, he may injure someone unknowingly. Install alarms where necessary. Hmm? Yes, 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 yes. Sleepwalking disorders under non-rapid movement sleep arousal disorder. We have talked about some things that are very important that are coming in here: alcohol, obesity, long hours without sleep. You have seen the things that are negative. Those are point to note when it comes to these problems. Now, we are yes, yes, people are so nightmare disorders. There's something we are at the ninth one, nightmare disorders. Nightmare disorders. You see, being a doctor or a health worker does not mean just to inject people and find issues that you can treat with the drugs. No. Hmm? It means please prevent a problem before it starts. So that's what I'm doing. Hmm? That's what I'm doing. I'm enabling you to know how to avoid some issues before they come so that you don't rush every time to a doctor's office. You get it? That is the better way of a doctor to treat someone rather than to wait until the mistake is there so that you start injecting and reversing the problem. Hmm? It's very important. And you see, mental health is the beginning of everything. Mental health is the beginning of every disease. Now, nightmare disorder is a sleep. This is the ninth one. Imagine we have gone up to the ninth one, talking about sleep disorders. Sleep disorders, my friends, is a sleep disorder characterized by recurrent, vivid, and disturbing dreams. You are sleeping and you are having very funny dreams, nightmares. You are sleeping and you are like watching a movie and a horror. There was a movie when I was a kid that was called The Saw. I never liked that movie. I never finished The Saw. That movie, I could not sleep. Hmm? So please don't give your children horrors to watch. PG programs in your televisions and put the right programs for children to watch. So, nightmare disorder is a sleep disorder characterized by recurrent, vivid, and disturbing dreams that typically involve threats to survival, safety, or physical integrity, and which lead to abrupt awakening with intense fear, anxiety, and distress. So, you see, recurrent, vivid, and disturbing dreams. Hmm? Threats to survive, security, or physical integrity. Upon awakening, the person rapidly becomes oriented and alert. When you wake up, you are alert. You can't like think that thing that you were dreaming of is there next to you. This is called this is called horror experience, nightmare disorders. It's like when you put on a VR and you are playing that game and you remove it and you come and find out it was just a game that you are playing. Hmm? You see, it is not due to substance or medication or other things. You are always having those dreams. Hmm? You are always having those dreams. What is the pathophysiology and features? Occurs in rapid eye movement, the one that we have come from. Second half of the night. Often you have slept and then the sixth hour you start having nightmares. Hyperactivation of limbic regions. We talked about the limbic regions, amygdala, hippocampus, dysregulation, arousal. Those are brain places that regulate whatever you are seeing in dream. Amygdala. You go back to the brain function at the video when we started mental health, you will see how we were relating with it. You see, if you ask several people that have had nightmares, they'll tell you this. They have been chased and attacked. They can like similar, falling and drowning and suffocation. I know everyone has ever dreamt of falling, eh? And suffocation and suffocating from something. Every person have had this problem once in life. Yes? Hmm? And then we have war, violence, and accidents, supernatural threats. You have been watching a horror movie and then you start seeing those things in dreams. Yes. You see, things we do will come recur. Our brains are like computers that store and produce when they are clicked on. Dreams are often realistic, high emotion, and remembered in detail. These are common in age 3 to 6 years when the person is growing, persistent and recurrent nightmares in adolescents and old adults. You get it? So there are so many things that come in dreams that we can manage. The management of nightmares, sleep hygiene, reduce stress, image rehearsal therapy. Patients rewrite the nightmare with a positive ending. When you have a nightmare, start thinking a positive ending. Lucid dreaming techniques. You see, avoid alcohol, very important. Stimulants, coffee before you sleep, or heavy meal before bed. And then there is psychotherapy as usual, exposure therapy. And then there are some drugs we give that can help you, like prazosin, alpha 1 blocker that helps you to reduce those episodes, or clonidine. Even clonidine may be used. When to refer this patient? When do you now say no? This one needs a professional. When these nightmares occur once per night, every night you have a nightmare, causing daytime fatigue, fear of sleeping. Sometimes people fear to sleep because they know they'll have a nightmare. Suspected underlying PTSD, post-traumatic stress disorder. We have talked about it. If someone has PTSD, please take this person to a professional so that this person may not start having a problem with sleep. Yes, we are about to finish. We are at our 10th one. We are going up to 12. Rapid eye movement, sleep behavior. You get it? Hmm? Now, the other one was non-rapid. Now we have rapid eye movement, sleep behavior. You see, they kind of like it's the opposite. Rapid eye movement, sleep behavior. That one, the other one was non-rapid. This one is rapid. How does it relate? If that it's the opposite. Is a parasomnia characterized by repeated episodes of vocalization and complex motor behavior during REM sleep, typically associated with dream enactment, unlike the other one, which is non-rapid, which muscles are involved. Patients with this lose this atonia, allowing them to act in their dream. You see, it allows you to act in your dream. Hmm? Repeated episodes of vocalization and or complex motor behavior. You dream as you do whatever you are dreaming. Hmm? Imagine you are dreaming of singing and you are singing. Yeah? Just imagine. You dream you are doing house chores. You've heard of a person who woke up, cleaned the house without knowing, and then went back to bed and slept very comfortably. In the morning, this person wakes up and asks, "Who cleaned my house, please?" Hmm? And then you say that that person is haunted. I've seen people at our rural homestead. A person wakes up at around 12 at night, takes a jembe, goes to the shamba, digs the shamba, and then go back, washes himself or herself, and sleeps. This is rapid eye movement behavior. It is not being, now you know these people, it is not being haunted. People say they are haunted. It is not being haunted. This is a problem that should be sorted out. Hmm? A rapid episode arousal sleep associated with vocalization or complex motor behavior. Motor behavior means associated with muscle. This behavior arises during typically 90 minutes after sleep onset. You sleep and then you wake up again, you go to your kitchen sink, you start washing the utensils. You after that you go back and sleep. This is very risky because you may burn your house while sleeping, because whatever you are dreaming is what you are doing. You are in the kitchen and you want to light up a matchbox Remember, you are sleeping. You may light at the wrong place and put on the gas. This is very risky. This is very risky, and I want people to know that this is not being cursed or haunted. It is issues medical. People say those people are haunted. No, it's issues medical. This behavior arises 90 minutes after sleep. Upon awakening, the individual immediately alert and oriented. If you wake up this person, he'll wake up and ask, what am I doing? What's happening? But if you don't wake this person up, this person will go back to sleep and he will sleep up to tomorrow and wake up and ask you people who did whatever he is. You see, it's very funny, but it's differentiated from the other non-response. The other one does not involve muscles. This one involves muscles and speech. Now, sleep without atonia and polymorphism. A history of suggestive, or if you have a history like of Parkinson's disease, Lewy body dementia, those are problems that may relate with this. You get it? And then we have the behavior causing significant distress. When you see this person is having a distress in the daytime, know that this is a health related issue. Now we differentiate from normal rapid EM plus rapid BD. Normal rapid EM, there is muscle usage, muscle paralysis, but the other one, it is absent. Dream enchantment in other one, there is no dream enchantment. You cannot talk. The other one you can talk. Recalls of dream often vivid in the first one. The second one, you cannot recall anything. Presents and matches action. You see, 90 to 20 minutes of dream from the first when you sleep. The other one is same. Now, in clinical features, you may find this one having violent behaviors like kicking, punching, jumping out of bed. Eh? Dreams are often vivid and intense. You are seeing whatever you are dreaming and acting upon them. Hmm? Recall the dream clearly upon awakening. When you are awake, sometimes you may recall whatever can cause injury to self or other people. So it's not a good experience. We should look at these people and help them. Usually seen in older adults, yes, above 50 years. What may make this person have this? Degeneration of dysfunction in the areas leading to loss of this atonia in the brain, neurodegenerative diseases like Parkinson's, dementia, multiple system atrophy. Dementia and multiple system atrophy may may make you have this. Yes, we continue with the next one. The next one today we have to finish sleep disorders. We always we avoid alcohol, remove sharp objects from this. The next one is restless legs syndrome. Leg syndrome. Restless. I think I have to paste, or I have to let me paste all these problems here so that a person can relate when when he. We have talked about several things. These are them. We have, let me see how much I movement. It's important you have those notes there. Those are the things that we are talking about. Very important things that we are talking about. Now, restless leg syndrome. What is restless leg syndrome? Is Is it that your legs are always walking or what? No, this is a kind of problem that affects some people when they are sleeping. Restless, testing this so that you can go through them. Restless, leg syndromes and details. Yes. What are restless leg syndrome? Restless leg syndrome is a sensory neurologic disorder characterized by irresistible urge to move your legs, usually accompanied by unpleasant sensation. It typically occurs during periods of rest or inactivity, especially in the evening or at night. Yeah? You see that? Let me repeat about this. Let me repeat you here. Is a sensory motor neurological disorder characterized by an irresistible urge to move the legs, usually accompanied by unpleasant sensation. It typically occurs during periods of rest or inactivity, especially in the evening or at night. You just feel like moving your legs around, moving your legs around, moving your legs around. Urge to move your legs begins or worsening during periods of rest. When you are resting, you feel like moving your leg. It's partially or totally relieved by movement. When you move your legs, you feel good and you feel relieved. It's worse in the evening or at night when you are sleeping. When you are sleeping, you kind of like feel moving your legs around are not solely explained by other conditions. There is no condition that can explain this. You see, this one is not really understood by dopaminergic dysfunction because in your brain you have something called dopamine that helps you feel pressure. So hypoactivity of dopamine pathway is a cortical CNS in the central nervous tissues, especially in the basal ganglia and spinal cord. So if you have hypoactivity, your dopamine is not functioning well, you may end up having this problem. Dopamine antagonists often relieve symptoms. So when you have an antagonist, a drug called levodopa, and you give this person will stay away from shaking the legs. Iron deficiency. Iron is a very important factor in life. So low iron levels is a substantial ganglia and spinal cord may bring this problem. When you have low iron, you may feel like shaking your legs every time so that you are stable. You see, it's very important when you have iron cofactor in your body. So take things that are good in iron, to help you not to have this problem. But you see, there are some people in their genetic factor, they are predisposed to this because of mutations. There are some genes like BTB, D9, MEIS one, those are genes that will make you not have enough iron. So you may be predisposed, so you need supplements always. Abnormal glutamatergic activity, those are neurotransmitters. So when you are sleeping, you are always checking your legs or your hands. Imagine you are from a wedding and then you go, when you are sleeping, you find out your partner is checking the legs. Eh, it's good to tell someone earlier before getting this aura. So for these people, we give iron supplements like ferritin. Ferritin is oral or IV, or we give it intravenous ferritin so that you may have a stable legs, not shaking them always. And then we can supplement with dopamine antagonists to bring out up dopamine like pramipexole or ropinirole. Alpha 2 ligands, iron supplements, opiates, benzodiazepine to relieve stress will help. We go to the last one. The last one is substance medication induced sleep disorder. Substance medication, that one is the 12th one. Today we have used a long hours here. The substance medication induced, we have talked about alcohol. We have talked about alcohol. And we have seen several things have come up to every disorder that we have talked about. And it's very important as you see, listen, some things you listen and practice. It will help our health issues. It will help our health issues. So when we talk about substance, what are we talking about? Substance-induced sleep disorder is characterized by disturbance in sleep, insomnia, hypersomnia, parasomnia, or mixed types that are directly related to the use of withdrawal or substance of medication, including drugs that are prescribed by us doctors, recreational substance like alcohol, and the others like shisha that you smoke, and toxins. Sometimes I call shisha and the pipes toxins. In diagon, it is diagnosed only when sleep disturbance is clinically and not better explained by none other or mental medical condition, but whatever you have taken. Hmm? A prominent and severe disturbance in sleep, difficult falling asleep, awakening, and excessive sleepiness. Hmm? The disturbance is judged to be caused by effect of a substance, drugs, of abuse, medication, or a toxin. When you go to hospital, someone does a good physical exam, or they take blood and they check the toxin in your blood to see what is in your blood, and then they come and find out this person is having sleep disorders because he took cocaine, or he took heroin, or this person took alcohol. Now, you see, this is particularly related to what a person has taken. Hmm? Sleep disorder is a very wide topic, and you've seen several factors that have come in because of sleep disorders: hypertension, diabetes, related issues of mental health issues. You get it? Hmm? We have even had sex related issues at this topic, sleep disorders. There are some neurotransmitters affected, like dopamine that gives you pleasure, serotonin affecting by antidepressants when you take a lot of antidepressants, norepinephrine and acetylcholine altered by stimuli like nicotine. Those people that smoke nicotine, they will get this. Orexin, hypocretin. Hypocretin, we have talked about it. It is in the cerebrospinal fluid. mm, By hypersomnia, when you stay or sleep a lot, you affect hypocretin. It cannot function well, so you'll have sleep disorder related to this. Orexin. These changes can lead to fragment sleep that you sleep and wake, suppression of the sleep pattern or deep sleep, rebound REM. You see, there are some things that we relate to like alcohol, caffeine, nicotine, and stimuli, sedative, benzodiazepine, antidepressants, opioids, cannabis sativa, all of them antipsychotics. Hmm? Clinical subtypes of these: insomnia, daytime sleepiness, parasomnia, types, mixed types. Hmm? Diagnosis: when you want to know this is a problem that has been brought by this, you do clinical history, you ask what did he take, what is he taking currently, any medication this person is. You do toxicology screening by taking the drug. You take the drug and do toxicology screening. Hmm? You see that? Very important. Stop, reduce offending. Those are the treatment. Yes, I can see Roger Killer in the house. You continue doing those things and they will help. I think we have talked a lot about sleep disorders. And next time we are tomorrow I think I will start with the treatment, because I think it is more than 2 hours and time is getting down. It's getting to 6:30 right now, here in East African time, 6:30. So I will say we have talked about sleep disorders, and the reason why I've brought about this topic of sleep disorders is because of one thing. We have seen diseases that are related to sleep disorders. Welcome, Roger Killer in the house. Roger Killer, Rogers Killer. Welcome. We are just coming while I'm finishing. There are so many diseases that are brought by sleep disorders that even us, we really need to know. We really need to diseases by okay. Okay, just a minute here. Yes, yes. Good work, good work. Now, sleep is a very, when we talk about sleep, we're talking about, we think about it's a very minute thing, a very minute thing. But you see, there are some things as I finish, I'll do the treatments of both tomorrow and the management tomorrow. But I want you to, as we finish, we get to know issues that can be brought by sleep disorders. There are issues that can be brought by sleep disorders. And when we talk about them, one is this depression. Why? Because of insomnia and hypersomnia. Those are sleep disruptions. And then we have anxiety disorders. Yes, jambo Roger Killer, jambo kabisa. Leo tunaongea kuhusu, that is Swahili everyone. I'm saying today we are talking about sleep disorders. Roger Killer has asked me in Swahili, so I'm responding jambo karibu. Okay, so these are the diseases that can be brought, or complications that can be brought by sleep disorders. As I'm ending, guys, tomorrow I'll do treatment of the 12 sleep disorders tomorrow, the same time. So if you have a question, you can put it up right now as I end. Depression is one of the problems that can be brought. And then we have anxiety disorders brought by insomnia. Bipolar disorder can be brought by sleep disorders, mainly insomnia and hypersomnia. Yes? Yes. Come again? Sema. Nini? Yeah. Okay. Just a minute, guys. Yes. I'm back. I was attending to someone, an emergency. Good. As I finish now, bipolar disorder can be brought by insomnia and hypersomnia, schizophrenia, sleep fragment. We talked about schizophrenia, dementia, disruptory. Remember about tomorrow we'll talk about dementia, but it can be brought by sleep is important for clearing beta amyloid. Poor sleep increase in cognitive decline. So you may have dementia and insomnia. Now, epilepsy, insomnia, Those people that are epileptic, lack of sleep increases seizure frequency. So if you have lack of sleep, it may increase seizures. Cardiovascular diseases, diseases related to your heart, diseases related to your heart may be brought by hypertension, can be brought by not sleeping, coronary heart disease, short sleep duration, heart failures. You are not sleeping okay, you'll get a heart failure. Stroke, insomnia. You see, heart failure is brought by sleep centers that bring you get it. So you may get heart failure. Endocrine, endocrine and metabolic disorders like type 2 diabetes, obesity, metabolic syndromes, thyroid dysfunction, all those can be brought by not sleeping well. Now, let me go on again. Mental and neurological issues that can be brought by not having sleep or having these sleep problems. The 12th one, mentally, you may get depression, anxiety disorder, bipolar disorder, schizophrenia, dementia, epilepsy, cardiovascular, the heart now and the blood, hypertension, coronary heart disease, heart failure, stroke. And then we have endocrine one. Endocrine glands are like thyroid, type 2 diabetes, obesity, metabolic syndrome. You get it? Sleep disruption contribute to dyslipidemia, insulin receptors. You are always having high cholesterol, metabolic issues. Think about the rest pattern you have. Thyroid dysfunction, insomnia, in immunological and infectious diseases, frequent infections, autoimmune diseases like lupus. You get it? Lupus, you may get them. Sleep, poor sleep quantity. People with lupus, think about poor sleep, even if it is autoimmune. The symptoms rises because of poor sleep. Respiratory diseases like COPD, chronic obstructive pulmonary disorder, and asthma. You get it? Musculoskeletal and pain this syndrome, chronic pain in your muscles. Osteoarthritis, disrupted sleep because calcium imbalance in your body, osteoarthritis. You see, there are so many things that you can get because of sleep disorders. Reproductive health, infertility. We will talk of infertility one day. Infertility, poor sleep patterns, infertility, menstrual irregularities, your hormones are bad because you don't have enough rest, you are having hormonal imbalance, you'll get menstrual irregularities. And then we have erectile dysfunctions because of fatigue, poor sleep quality, and reduced testosterone. When you have poor sleep quality, you'll have not enough testosterone. So system affected when you have poor sleep pattern. We talk about mental health, that is about the brain, cardiovascular, metabolic, that is like the diabetes and obesity, immune issues, respiratory issues, neurological issues, and musculoskeletal issues. Even reproductive, you have seen. So insomnia, obstructive sleep apnea, circadian rhythm disorders, major risk factors, many chronic diseases. Good sleep is a luxury but critical component of preventing curative health issues. Very important. Now we stop there for if no one has a question for the day. Let's stop there for today because you have seen I've started being called. See 1, 2, 3 people. Uh, Raise your questions. Please share. Tell your friend. Tell anyone that we talk about mental health and other issues here. If someone has a problem, let's discuss it here. Let's help people out there. If you have a private question, there is an email pinned there. Please follow it. And thanks to everyone in the platform. Thanks to everyone who has come about and liked the video and shared again. Tomorrow we will talk about Dementia. Dementia. Tomorrow is dementia. Yes, Tennessee Sky. Tomorrow is dementia. So be blessed and everyone stay good. Till next time, come with questions tomorrow. See you. Good day. Bye bye.